Hello everyone, welcome to Patho Excellence. In this episode 15 of Endometrial Pathology video series, today we are going to discuss serous carcinoma and clear cell carcinoma of endometrium in detail. In last video we have discussed endometrioid carcinoma. So now we have to differentiate whether this is endometrioid or whether it is serous or clear cell carcinoma. So, in this video, the topics to be discussed are: first is serous carcinoma, its clinical gross microscopic features, and serous carcinoma confined to a polyp. Synchronous serous carcinoma means uterus versus ovarian serous carcinoma, how to differentiate when both are involved, and what is the primary that we have to identify. Uh, Another thing is staging issues with serous carcinoma and IHC and molecular mutation. And next topic will be clear cell carcinoma in detail, including all these morphological features, IHC and molecular mutation. So let's see one by one what is serous and what is clear cell carcinoma. So basically serous and clear cell carcinoma are biologically aggressive tumors and whose behavior is independent of tumor size, depth of invasion or apparent confinement, and they are type 2 endometrial carcinomas. Endometrioid carcinoma is type 1 carcinoma. This is high grade by definition and managed by systemic disease and not organ confined tumors. Now let's begin with endometrial serous carcinoma in detail. So first of all, origin and pathogenesis, if we see, it is arising from atrophic endometrium mostly. Precursor lesion is endometrial intraepithelial carcinoma. This EIC may exist without invasion, and even non-invasive lesions can metastatize. So key concept is that invasion is not required for dissemination. Second, size and behavior paradox means tumor may be small, polyp confined or superficial, yet they show ovarian metastasis, peritoneal spread or lymph node involvement. So basically extent of disease, not the tumor bulk, determines prognosis. So even the tumor is small, there are chances of metastasis. Now clinical features, this serous carcinoma account roughly 10% of all endometrial carcinoma and 40% of death related to endometrial carcinoma. This typically affects postmenopausal women, arises in atrophic endometrium. This carcinoma may occur in setting of prior pelvic radiation for cervical cancer, tamoxifen therapy for breast carcinoma, BRCA1 mutation and breast cancer. So, it generally present with postmenopausal bleeding and highly aggressive with early extrauterine spread, and its prognosis is poor. So, gross, if we see, it may appear as a small polypoid lesion with or without hemorrhage and necrosis, and sometimes minimal or inconspicuous endometrial thickening, and often disproportionately aggressive relative to tumor size. Even though small in size, it may have an aggressive behavior. Deep myometrial invasion may be absent or minimal, and extrauterine disease common even with superficial tumor. So here we can appreciate, see, this is the endometrial surface and it is involved by this carcinoma showing polypoidal and thickened appearance of the tumor mass, and areas of hemorrhage and necrosis is present. Now microscopic features defined by that this is a low grade architectural pattern but high-grade nuclear atypia. It is the defining feature, and architecture may appear deceptively well differentiated. Now, main component is papillary architecture. Most commonly, they are present with coarse complex papillae with thick fibrotic stromal core, and it is lined by stratified malignant epithelium. There are presence of arborizing papillae with multiple uh, secondary tuft, and papillary fronts are broad and rigid, unlike villo-glandular pattern of low-grade endometrial carcinoma. This low-grade endometrioid carcinoma will have a thin and slender papillary front. Here it is broad and rigid. And papillary tufts are also present. They are free floating clusters of tumor cells and without stromal pores. It represent dense epithelial aggregates of tumor cell. So now here we can see these are the papillary fronts, and this is called arborizing pattern because this is a branching pattern, means one papillae is there and it is having a multiple branches. So this is called arborizing pattern or arborizing papillae with multiple papillary tuft, and this tumor may have these free floating clusters of cells also. Now here we can see uh, these are complex papillary uh, fragments, and here fibrovascular core with here you can see this is the slit like spaces. So this is a complex papillary neoplastic proliferation, some of having detached papillary tuft, and it is having high grade malignant nuclear features. So fibrovascular core, it is the characteristic papillary feature having malignant cells having high NC ratio, pleomorphism, and you can appreciate at some places prominent macronucleoli. Now architectural diversity is generally seen because this is not purely papillary. Some area may show papilla, some show glandular appearance, and solid component is also present. Glands may show gapping lumina, especially in myoinvasive areas, and cytologically if we see, there is marked nuclear pleomorphism, high NC ratio, hyperchromatic nuclei with macronuclei, numerous mitosis including abnormal mitotic figures, and nuclei may be lobulated, deeply cleft, or having smudged chromatin. Other than these, additional features include psammoma bodies which can be present in some of the this serous carcinoma, and it is up to 1/3 of cases show this psammoma bodies presence. Generally tumor cells are round, abundant granular eosinophilic cytoplasm, and sometimes foci of clear cell change may be present. So in next tumor that we are going to discuss is clear cell carcinoma. So we have to differentiate it from clear cell carcinoma also if clear cell changes are present. Now, so key diagnostic principle is all serous carcinomas are high grade by definition, because nuclear grading is here not applicable because they are high grade only. Now here we can see this is the another pattern of serous carcinoma, means this is a glandular pattern. So papillary we have seen, this is glandular pattern, but here the nuclear features are high grade in nature, and this tumor is having stratification, loss of polarity, high NC ratio, some of having prominent nucleoli, and mitotic figures. So whenever there is glandular pattern, we have to see or differentiate it from the atypical hypoplasia, but with the help of this high grade nuclear feature, we can differentiate it from this atypical hypoplasia. Now Samoma bodies. These are the bodies, they are laminated calcified bodies. These are the high grade nuclear features of serous carcinoma. And what is Samoma body? So Samoma bodies is nothing but the concentrically layered calcified structure present due to cell death and inflammation within the tumors, and its appearance is pink or purple on He stain, purplish on Pap stain, and they are round and laminated. And significance is that its presence indicate classic feature of high grade serous carcinoma of ovarian origin or fallopian tube or uterine serous carcinoma, and it suggests aggressive nature of the tumor. This is again a third pattern of serous carcinoma. Here you can see the solid infiltrative pattern of the tumor cells. There is no glandular pattern, no papillary formation, but solid areas of the tumor cells are present, and in between there is inflammatory infiltrate in the stroma. So this is infiltrative solid pattern, irregularly shaped. Uh, some of the area shows slit-like spaces may indicate glandular architecture, nuclear pleomorphism, hyperchromasia, and high-grade nuclear feature. This is a constant feature. This is the high power view. Easily you can appreciate nuclear high-grade features. So this is papillae, multiple papillae here, and these tumor cells are enlarged, having large nucleus, high NC ratio, prominent macronucleoli. Some of you can appreciate here in high power view eosinophilic cytoplasm, and most important thing, these are the mitotic figures, they are abnormal in nature. So this is a classic feature of serous carcinoma. Now papillary features we have discussed. So it is not necessary that papilla if seen it is serous carcinoma. So whenever we see papillary features in endometrial carcinoma, any type, either endometrioid or serous or whatever, we have to go for its nuclear features. So whenever papillary architecture is seen, what is the diagnostic approach? So here you can appreciate, so papillary growth either identified in endometrial biopsy or hysterectomy specimen. We have to evaluate nuclear grade or and pleomorphism, hyperchromasia, prominent nucleoli, and mitotic activity. So with the help of this, if high grade nuclei are present or marked nuclear atypia or abnormal mitosis is present, one and only it is serous cell serous carcinoma, and it is generally having papillary tuft with coarse and thickened fibrovascular core having aggressive behavior. Now suppose these nuclear features are having low or moderate grade nuclei, then we have to assess papillary pattern, whether it is long slender branching or thick or coarse. So if they are long, slender and branching formed with columnar lining but no papillary tuft, then it is going into the classification of villo-glandular pattern of low grade endometrioid carcinoma. So ultimately we have to focus on nuclear features and papillary architecture with its fibrovascular core. Now in between this, so it is intermediate features like slightly coarse papillae but grade 2 nuclei, then we have to give its a grade 2 endometrioid carcinoma, but we have to perform IHC whether they are P53 or P16 positive or ERPR responsive or not. So with the help of this IHC, we can differentiate whether it is low grade or grade 2 or whether it is serous carcinoma. So bottom rule is avoid term papillary carcinoma. Because of papillary nature or papillary architecture, we cannot give its name a papillary carcinoma because papilla are present in most of the or many of the endometrial carcinoma, and diagnosis depend on nuclear grade and architecture. Now, what are the IHC markers that will help us to identify the serous carcinoma? So, IHC marker role is that it assists diagnosis when morphology is equivocal. It does not replace morphology. So, morphology identification is must, and key marker is P53 immunohistochemistry. It is showing more than 75% cells. So, diffuse strong nuclear overexpression most common, or correlate with TP53 mutation in 90% of cases. Now, this P53 staining having 4 patterns. These patterns we have already discussed in previous videos. So, if you want to learn this staining pattern, so you check this video for P53 staining pattern. But here in short, there are 4 patterns. One is overexpression, means strong diffuse nuclear staining pattern, more than 75% cells show this, and it's surrogate of TP53 mutation. Second is null phenotype. Null phenotype means totally absence of tumor cell staining with internal control positive. Third pattern is cytoplasmic only staining. So, no nuclear staining, but cytoplasm of the tumor cell shows a positivity, and internal control show wild type nuclear pattern. And what is wild type pattern? Wild type means variable intensity and scattered, only some of the cells show positivity, and it not a surrogate of TP53 mutation. So, for the TP53 mutation, staining must be overexpression or strong diffusing nuclear staining. Now, additional other than P53, which are the markers? So, one is P16. So, diffuse strong positive indicate or it supports TP53 mutation. It helpful in confirming P53 null phenotype. Patchy staining suggests non-serous carcinoma, and Ki67, which is important, where you can identify mitotic figures and its uh, mitotic index we can judge with this Ki67. So, proliferative index we can judge with this Ki67. Now, hormone receptors, most are ER and PR, which is negative. If we see endometrioid carcinoma, they are ER and PR positive. So, it helps distinguish from low grade endometrioid carcinoma. WT1, sorry, here it's Ki67 showing diffuse nuclear positive, and some CK7 and AE1 and AE3, it is giving strong membranous staining. Along with the PAX8, it is strong nuclear staining. Now, MLH1, PMS2, PMSH2 and MSH6 are typically retained. So, these are the important markers, but negative markers are also important, like I already said, ERPR negative, WT1, which is ovarian serous carcinoma, are strong diffuse positivity, and here these endometrial serous carcinoma are usually negative, but some endometrial cases may give WT1 positive. So, we have to interpret cautiously with the help of all other markers. Another is important HER2, because it is positivity and its expression is helpful for treatment modality like this. Trastuzumab use is helpful for the patient when this HER2 positive carcinoma is there. So this intense, complete or basolateral or lateral staining for HER2 is seen in less than 30% of the tumor cells, and this patient with this advanced stage HER2 positive endometrial serous carcinoma benefit from this treatment. And here let's see IHC marker. So here it is diffuse positivity with the P16, which is cytoplasmic positivity, and all the tumor cells are positive with this marker. This is again another marker which is P53. It is strong, or it is called diffuse nuclear pattern, or it is aberrant or overexpression, and it is suggestive of glandular pattern of serous carcinoma. Another marker that we have discussed is HER2, which is either basolateral, means lateral wall and basal area, or only lateral wall set staining of the cells. Here it is present in less than 30% of tumor cells. Some of the cells are negative, so it is +2 by criteria for trastuzumab use. Now molecular alteration if we see, one is TP53 mutation. So essentially WHO says that cytologically high grade endometrial carcinoma with complex papillary or glandular architecture and abnormal P53 and diffuse P16 IHC positive, then it is serous carcinoma. Second, TCGA. So the cancer genome atlas here shows copy number high group, and there is genomic instability, and this is not associated with P10 mutation and microsatellite instability, which is generally associated with endometrioid carcinoma. Now biological behavior, if we see, most commonly in older women 7th decade, and there is high grade tumor with tumor size, depth of invasion or polyp confinement. It is not associated with all this. So any size, any depth or any polyp related even small tumor may get metastatized. So pattern of spread, if we see, deep myometrial invasion is common, lymphovascular permeation is frequent, and peritoneal dissemination may be, or most of the cases show this dissemination even the tumor is having small polyp size growth, and may mimic ovarian serous carcinoma. So we have to differentiate with the help of IHC and another panel. So we will discuss how to differentiate ovarian and uterine serous in next few slides. It can be minimal invasive, it can be confined to endometrial polyp and only present on curettage. So what is minimal uterine serous carcinoma? When there is less than 1 centimeter or a non invasion, so it is called minimal uterine serous carcinoma, but it is having capacity of widespread metastasis. Now mixed carcinoma or mixed tumors. So what is classification rule? So if more than or equal to 25% serous component is present, it is classified as serous carcinoma. More than 5% but less than 25% serous component, so it is mixed carcinoma with serous component. And less than 5 or equal to 5% serous component, usually it is endometrioid carcinoma, and we have to correlate with IHC. Now this is a serous carcinoma confined to a polyp, a very small polyp present in endometrial cavity may show high grade features of serous carcinoma, without any myometrial invasion. And here we can see this is normal lining of this endometrial cavity, and here you can appreciate this nuclear feature having high grade features, and this is a polyp lining. So polyp lining, this is normal cystically atrophied gland of polyp, multiple cystic atrophic glands, and this outer wall or its lining shows high grade feature of serous carcinoma, and it is confirmed by P53 overexpression. So this is the P53 positive cells, and here this endometrial atrophied gland show negative expression of P53. So though it is confined to endometrial polyp, no myometrial invasion, having high risk of extrauterine spread, and it requires full surgical staging. So be careful whenever you see polyp in endometrium of older women. Uh, you have to thoroughly take sections, or you have to whole pass polyp to rule out any uh, chances of serous carcinoma. So it should not be considered low risk, because it can be metastatized to any uh, part of the uterus, ovary or fallopian tube, or even peritoneal or lymphovascular area. Now, sometimes with this tumor, you can find tubal spread. So, we have to differentiate whether it is tubal spread of endometrial carcinoma or it is serous tubular intraepithelial carcinoma. So, it is called STIC. So, uterine serous carcinoma can spread to fallopian tube mucosa, which mimic STIC, and its involvement does not equal tubule origin. So, whenever it is present with uterine serous carcinoma, it is generally a tubal spread, and this stick-like lesion may represent metastasis, so it is not a primary disease. Now, sometimes this tumor is very high grade, so patient present with uterine mass as well as ovarian spread also. So this called synchronous serous carcinoma, uterus versus ovary. We have to differentiate. So diagnostic challenge is whether serous carcinoma may coexist in endometrium and ovary. So what is the primary site? So it is very difficult to assign. Morphology alone is frequently inefficient, and key principle is that distribution of disease is the most important diagnostic clue. Let's see what is the clue. So site of origin, if we want to identify, so which points favor so uterine origin. So one is bilateral ovarian involvement, largely or deeply infiltrative endometrial carcinoma, myometrial invasion plus or minus lymphovascular invasion favors uterine origin, and ovarian disease relatively superficial or secondary. So whenever we see a bilateral ovarian involvement along with these all features, it favors uterine origin. Now, what are the points which favors ovarian origin? So mostly it present a single dominant large ovarian mass. Endometrium is also involved, but only surface involvement or serosal spread without deep myometrial invasion. So these are the clues. Now, what is the role of P53 when we want to differentiate uterine and ovarian mass? So it is not definitive, it is adjunctive, helpful only in select or a few cases, and it support different primaries when one tumor show P53 null pattern and another tumor show diffuse overexpression. Means suppose uterus and ovary both have serous carcinoma, but section from the ovary shows either P53 null pattern and section from the uterine mass shows diffuse overexpression. Then it is different primaries, that because tumor cells from single origin have similar features or similar expression of this P53 IHC. So whenever we have both pattern in a different origin, then it is independent origin. So identical P53 pattern does not or do not exclude metastatic spread. So this is again a one catch. So basically we have to look for all the features as well as IHC marker whenever we get uterine as well as ovarian serous carcinoma. Now staging issue. As we have seen that this serous carcinoma is high grade in nature by definition. So here staging is challenging because deep myometrial invasion is common. It may be grossly inapparent and require aggressive and extensive myometrial sampling. And deep invasion leads to increased risk of extrauterine spread. Second is peritoneal and omental spread. So its behavior is similar to ovarian serous carcinoma. And here along with this peritoneal and omental spread, fallopian tube assessment is very much important. So at that time we have to submit whole tube or entirely submission of tubes are required. Small intraluminal tumor deposits correlate with peritoneal disease, and stick-like lesion may represent tubal spread. So it is not necessarily a second primary, it is generally a spread from the uterine serous carcinoma. So uterine serous carcinoma require comprehensive surgical staging irrespective of depth of invasion due to its aggressive biology and early extrauterine spread. So by nature it is high grade serous carcinoma. And here whenever we see fallopian tube or peritoneal omentum or myometrium, we require careful sampling because uh, even uterine lesion is very minute, we can identify spread in this all organs. Lymph node staging, generally without deep invasion also we can find high propensity for lymphovascular invasion, and nodal metastasis can occur despite superficial myometrial involvement. So this is about serous cell carcinoma. Let's move to endometrial clear cell carcinoma. So endometrial clear cell carcinoma, if we see clinical features, again similar to serous carcinoma, present or occurs in older postmenopausal women, abnormal uterine bleeding, less common than serous carcinoma, aggressive in nature but slightly better prognosis than serous carcinoma. Now microscopic features. See, gross features we cannot differentiate grossly serous or clear cell or endometrioid carcinoma because it is generally present as a either polypoidal growth or thickening of endometrium or ulceration, etc. So microscopically if we see cytoplasm and cells, tumor cells show clear vacuolated cytoplasm, and characteristic feature is hyalinized stroma and papillary cores. So clear vacuolated cytoplasm indicates or its name given is clear cell carcinoma due to its clear cytoplasm. Papillary cores also present with hyalinized stroma and nuclei. If we can identify, there are chances of hobnailing cells in which nuclei bulge into glandular lumen. Clear cytoplasm may be inconspicuous, and we have to distinguish it from benign metaplastic hobnailing in abnormal uterine bleeding, because this clear nature is due to glycogen. Normally in benign lesion also we can find this hobnailing as well as clear cytoplasm. Here this is not necessary that only clear cells carcinoma show clear cytoplasm. Some of the tumor cells may show eosinophilic or pink cytoplasm. So at that time it is difficult to diagnose clear cell carcinoma. At that time we have to see architectural pattern, whether it is tubulocystic or glandular or papillary or solid. So nuclear features, its association and differential diagnosis include, by definition it is high grade and marked pleomorphism. So differential diagnosis include, with the help of nuclear feature, it is serous carcinoma, endometrioid carcinoma with secretory change, and endometrioid carcinoma with clear cells. So usually nuclear features we have to focus on, and in this endometrioid carcinoma with clear cell show low grade nuclear features, while clear cell carcinoma is having high grade nuclear features. So what is high grade nuclear feature include? It is marked pleomorphism, macronucleoli, abnormal mitotic figures, but it is less frequent than serous carcinoma. Psammoma body is occasionally present, and its association with serous carcinoma we have to differentiate whether it is admixed with serous carcinoma or there may be morphologic overlap, and up to 14% of serous carcinoma show clear cell change. So these resemble serous carcinoma, not true clear cell carcinoma. So we have to be careful when we uh, go for this type of overlap. Now if we see microscopically, here you can appreciate these are the papillary pattern with hyalinized core, and these tumor cells show hobnailing pattern. They are protruding from the surface and having clear cytoplasm. It is difficult to see here, but you can appreciate papilla, hyalinized core and hobnailing pattern. This is again a glandular pattern. Here you can appreciate clear cell nature of the cell. Cytoplasm is clear, and see this is clear cytoplasm here. Prominent nucleoli, dot like nucleoli you can appreciate, and this is a glandular pattern. So this is glandular pattern clear cell carcinoma, but having high grade nuclear features. This is helping us to differentiate it from atypical hypoplasia, where nuclear features are having uh, less aggressiveness than compared to this. So this is gland having clear cell carcinoma feature. Now in high power view, here you can appreciate no glandular, no papillary architecture, means solid pattern of the tumor, easily appreciable clear cells, clear cytoplasm, nuclear pleomorphism, hyperchromasia. Some of the area show this is mitotic figures and prominent nucleoli. So this is solid pattern and high grade nuclear or grade 3, and some of these here you can appreciate apoptotic bodies. Here hyaline core with papilla, with hobnailing pattern and clear cell nature. So this is eosinophilic hyalinized core which is characteristic of this clear cell carcinoma. These are the tuft of papilla having clear cells and showing hobnailing pattern of the nuclei projecting onto the surface, while here you can compare nuclear feature in both the section. See, here these are the nuclear feature having benign appearance and lack of cytological atypia. Compare here, this is high grade nuclear feature. So, this is hobnail metaplastic change which mimic clear cell carcinoma, and we have to see nuclear atypia to rule out whether it is high grade carcinoma or just a metaplastic change, because here also patient present with abnormal uterine bleeding, and we can use panel like P53 and Ki67 to differentiate from clear cell carcinoma and metaplastic change. So this is important. Now here again this is a section showing clear cell carcinoma features, and this is the hyaline stromal area. This is the characteristic feature, clear cells with high grade nuclear features. This is again a high power view, little bit uh, uh, called serous like nuclear feature, but this portion is compared to serous carcinoma, or amount of the this type of atypia is less, and some of the cells here show pseudo inclusion. So this is nuclear pseudo inclusion. It is also a common finding. Here it is bizarre atypical cells, and this is again a section of clear cell carcinoma. Now if we see IHC, then most common IHC profile which is helpful to identify some molecular mutations like PIK3CA or ARID1A, we require HNF1B, Nepsin A, P53 wild type or aberrant expression, ERPR negative, and WT1 also negative. So these are the clear cell carcinoma IHC profile, and TP53 mutation is less frequent than serous carcinoma. So because TP53 mutation is less frequent, P53 show wild type or aberrant expression, and it is molecularly heterogeneous group, and its clinical behavior same as like serous carcinoma, aggressive in nature. It is defined as a high grade aggressive tumor characterized by clear or hobnail cells, hyalinized stroma, and multiple architectural pattern, ERPR negative and supportive but not specific IHC, non-specific IHC marker, primarily in older women, high relapse rate, and it is clinical behavior is similar to serous carcinoma. So what is the take home message for all or both the serous and clear cell carcinoma? First, serous carcinoma behaves as a systemic disease from inception. Polyp confined, it is not like low risk, it is a high grade nuclear feature that indicate its aggressiveness. Tubal lesion may represent spread and it's not origin. Clear cell carcinoma is architecturally defined, and whenever we see either serous or clear cell carcinoma, we have to go step by step approach, which includes morphology, what is the distribution, what is the nuclear feature, and what are IHC panel that is indicating its mutation, and what is the molecular mutation that is important for this serous and clear cell carcinoma. So, by definition, serous and clear cell carcinomas are high grade tumor irrespective of invasion. So, morphology come first, IHC supports the diagnosis, and staging must always be meticulous. So, I hope now you can easily identify serous and clear cell carcinoma under microscope. If you found this video helpful, please like, share and subscribe this channel to get more such videos on endometrial pathology. Our next topic will be carcinosarcoma and other tumors. So thank you and stay tuned.